Good morning, everyone. I would like to introduce my PhD topic, which is about conservative therapeutic possibilities for temporomandibular disorders. My name is Kata Kelemen, and I'm working at the Department of Prosthodontics at Semmelweis University. My vision is to establish a TMD treatment protocol that is available for all patients, apart from the localization of the dental offices, and also to make an emphasis on prevention and therapy as well by a multidisciplinary team. Here you can see my two specific goals. I would like to investigate the conservative therapeutic possibilities for myogenic and for arthrogenic temporomandibular disorders as well. My first topic is about investigating the efficacy of combined therapy to physiotherapy in adults with myogenic temporomandibular disorders. TMD is the third most common stomatological disorder, and the 10th or the 15% of the population has this kind of disorder. The most common type is the muscle disorder group, which can be above 45%, and its therapy we can use either occlusal splint therapy or physiotherapy as well. The unmet need for this topic is to find a pain-relieving method, so our aim was to investigate which reversible and conservative therapy offers the best results in increasing the symptomology. We phrased our question, which is there a difference in efficacy of additional occlusal splint therapy to physiotherapy in adults who have myogenic temporomandibular disorders? As a population, we choose adults with local myalgia and myofascial pain. The intervention was additional splint therapy to physiotherapy, manual exercise, education, and counseling. And the comparator was physiotherapy, manual exercise, education, and counseling. And as a primary outcome, we measured the range of motion, and we measured the pain perception as well on a visual analog scale. As a secondary outcome, we measured the quality of life. Our hypothesis was that the additional occlusal splint therapy is more efficient and it offers best results. We have done the systematic search in 4 major databases, and 7 articles were eligible for this one. Here you can see some of my results. The first one is about comparing pain perception on a visual analog scale at baseline, and then the 1 month follow-up as well between the splint group and the control group as well. In both studies, 5 articles were included. The population heterogeneity is quite big because in the last article, the patients could take some painkillers, so that can modify our results. And the effect was mean difference. There is a mathematically and clinically significant result as well. But if we are observing the difference between the two groups, we can see only a slight difference, and as a conclusion, we can questioning the usage of the additional splint. You can see my second outcome, which is comparing maximum mouth opening at baseline and at the 4 weeks follow-up. In each cases, 2 articles were included. The population heterogeneity is quite big, as in some of the articles they were using some subgroups as well. And there was no mathematically significant data, but clinically all our results are relevant, as the results shows that more than 3 millimeters the increase in the maximum mouth opening in both cases. As our summary, all the included studies were randomized controlled trials, and the exclusion criteria was quite homogeneous, as there was no general diseases. And all the studies were using the DCTMD, which is a protocol for temporomandibular disorders. Some long-term follow-ups was also included, and in each case, the additional splint was the Michigan splint. Unfortunately, we had some limitations, which was the number of the studies. The heterogeneity was quite big in all population, and the physiotherapy was conducted at home under different settings, so some exercises cannot be controlled. As our conclusion, there was a small difference change between the intervention and the control group as well, but also we can questioning the usage of the additional splint therapy in myogenic temporomandibular disorder, and we should make a bigger emphasis on physiotherapy as well, so we need a multidisciplinary team in the treatment. Also, to distinguish our results, more RCTs should be implemented in this field. The implication for practice is we should reconsider the usage of the additional splint therapy as the first non-invasive therapy in myogenic temporomandibular disorder. We need a multidisciplinary team, and also we should involve more physiotherapists in the field. For the research, we should facilitate more investigations on single splint therapy and on pharmacotherapy as well, and we should restrict the inclusion criteria as some psychosocial conditions can affect our outcomes, and also some more long-term follow-ups are required. I have submitted my manuscript at the Journal of Dental Research, and right now I'm waiting for the answer. As my second topic, I was investigating the efficacy of different medical devices in the treatment of temporomandibular disorders. The 8% of the population has this kind of disorder, and arthrocentesis is in intermediate phase between the medical and the surgical forms of the treatment. It can be done under local anesthesia, and we wanted to examine the efficacy of ringer solution, hyaluronic acid, PRP, and steroids as well. But unfortunately, there was a network meta-analysis in this topic in 2019. So we added some other medical devices, which was glucosamine and chondroitin sulfate. And our aim was to investigate the efficacy of these medical devices and also to find a pain relieving method in this field. Our question was the following: is there a difference in efficacy of different medical devices in the management of arthrogenic TMD? The population was TMD, and we used the Wilks stage. We involved Wilks stage 2 to 5. The intervention and the comparator were some medical devices, and the outcome were range of motion and pain perception as well. I have done the systematic search in 4 major databases, and at the end of the selection, there were 22 eligible articles. According to Oxon, the temporomandibular disorder has some main symptoms. The first one is the movement restrictions, and we can measure it with a ruler or with a caliper in millimeters. So these are considered to be the primary outcomes, as these are objective. And we can make an analysis in maximum mouth opening and protrusion as well. The second main symptom is the pain perception, and it can be determined on a visual analog scale. As this is subjective, it's our secondary outcome, and also we can make an analysis on sound effects as well. This is also a secondary outcome, and it was measured on a visual analog scale as well. Here you can see some of my follow-up periods for the outcomes. We included short terms and long-term follow-ups as well. In the short-term follow-ups, we included the 1 week, the 1 month, and the 3 months. And then the long-term included the 6 months and the 1 year follow-up as well. But due to the lack of time, I would like to introduce only my 3 months and the 1 year results of mine. Here you can see my primary outcome, which was maximum mouth opening at 3 months. 4 interventions were included, and on the right upper corner we can see the Sukra plot, which is the ranking of the intervention, and the higher the Sukra value, the better the therapy the ranking gets. And here you can see some clinically and mathematically significant data as well. The 12 months results shows no mathematical significance, but also there is a clinically relevant data. For example, in the saline and PRP combined therapy, we can get an increase in maximum mouth opening with 3 millimeters. Our secondary outcome was the pain perception at the 3 months follow-up, and the best ranking we get with the saline and PRP combined therapy, and we can see a clinically and mathematically significant data as well. This tendency is growing at the 1 year follow-up as well. As the strengths, we included all medical devices that can be used in arthrogenic temporomandibular disorders. All the involved studies are randomized control trials, and long-term follow-ups are also involved. We conducted a network meta-analysis, so you can see a direct and an indirect link between all the treatment possibilities, and we could show some statistically and clinically relevant data as well. Unfortunately, we had some limitations. For example, in some of the articles, they were using some additional splint, and they were using different type of hyaluronic acid as well. As our conclusion, all the mentioned medical devices can be used for the management of arthrogenic temporomandibular disorders, and the best results came with the saline and PRP combined therapy. As a summary, we should reconsider the single usage of saline injection, and also we should consider the complex therapy in the management of arthrogenic temporomandibular disorders, and we should investigate chondroitin sulfate and glucosamine in more randomized controlled trials, but also some more follow-ups are required. I have done the grade assessment in my second project, and I'm starting to write my manuscript, and I would like to finish it till the 1st of October. And I would like to thank you for your kind attention with a quote: "If the plan does not work, change the strategy, but never the goal."
Thank you for the presentations, and I have so many comments. I would like to invite you for lunch, but don't worry, only for today. So you are familiar with the diagnostic criteria for temporomandibular disorders, and don't forget the secondary axis, so the mental part of this pain, which is related or not to the temporomandibular joint. So are the articles, the papers dealing with the emotional part of it? Because my specialist colleague, Dr. Somoshkövi, used to tell me at the second visit, without any treatment, most of the patients are very happy, and most of the symptoms are reduced. First of all, Dr. Somoshkövi is a handsome and very kind guy, but I think it's pretty important part of the treatment.
Yes, unfortunately, these articles did not include the second axis of the DCTMD, despite the fact that I have contacted to all the authors, but I could not get any information, so that's a big limitation of our work.
So I think it's a reasonable point, and I'm afraid about the reviewers' comments because of this.